مفيد إن شاء الله بإذن الله. بنرحب بأخونا وصديقنا وسافرنا في أمريكا الدكتور أحمد هميمي صديقي العزيز. هيدينا presentation على Radiology of Post-Focal Therapy of the Prostate.
صباح الخير، السلام عليكم. I'm honored and privileged إن أنا أجي في الكلية اللي بنتمي إليها والجامعة اللي بنتمي إليها والقسم اللي بحبه والناس اللي ليا معاهم تاريخ وتاريخ وتاريخ وليهم أفضل عليا، والبانل لوحدهم يعني لحم كتافي من خيرهم، وكلكم ما شاء الله زملاء أعزاء. This is the most advanced thing we're speaking about gene urine, which is imaging of post-focal therapy. And why is it advanced? Because the whole thing about focal therapy is new. So what type of focal therapy that we're giving to the prostate? There's a lot of multitudes of energy-driven intervention that we want to do for focal lesions in the prostate that prove to be cancer. So we're treating cancer here. We're not treating benign prostatic hyperplasia. We're not treating abscesses. We're treating cancer. So the main aim is to totally abolish local cancer. And instead of doing the classic treatment of radical prostatectomy, now there's an element of focal therapy. And the types of focal therapy is variable. The most famous is HIFU, cryotherapy. Laser has been on the verge for the last 10 years. There's a new procedure called TULSA, which is an MR-guided transurethral ablation of prostatic lesions. And vapor ablation still under trial, but there's a bit of some promising and some disencouraging results, but we still work on it. So the main advantage of all focal therapy thing that we are driving, pushing a very high energy to totally abolish local cancer, okay? With a good safety margin and in the same way preserving the sexual and MICT ratio. So this was introduced because there's now an element called active surveillance. In my days, which is almost 30 years ago, cancer is cancer, have to be removed totally. We follow up everything and we abolish everything. Now there's an element, some people can live with cancer and they are put on active surveillance. The prostate and the thyroid are two famous organs. So it's according to the grading, the staging of this lesion that we can do whatever we call active surveillance. And if we're going to jump from active surveillance into the next procedure in a very focal disease, we can offer focal therapy, preserving sexual functions, make the patient doesn't need any suprapubic catheter for life, for example. So it's very intriguing, and it's now, we're seeing it more and more often. So prostate equals PIRADS, but this is not for focal therapy. We are using PIRADS for diagnosing and diagnosing focal lesions, grading focal lesions. I know we have a great course. We're expecting a great course about prostate therapy from A to Z. But in a glimpse, PIRADS is for a benign lesions and for focal cancer without intervention. Once there is an intervention, BI-RAD stops. We cannot BI-RAD it. If there is even the intervention is therapy, radiotherapy. If we have some radiotherapy seeds in the prostate, we really cannot BI-RAD as much. That's why we have the problem, how we're going to evaluate focal lesions for focal recurrence. There is also some abnormality in the prostate using focal therapy, which is like scar, inflammation, altered vascularity, and most important thing is hemorrhage. Whenever we have a hemorrhage or calcifications, one of the major tools we're using for BI-RADS is diffusion weighted imaging and ADC. Whenever we have hemorrhage, everybody knows we don't know how to do about it. Diffusion go astray, we cannot really go through it. So we need to have a more elucible tool to diagnose focal therapy recurrence. So, just in the prior 2 years, there are 2 systems that were introduced for management of focal therapy. These 2 things, one called as Target, which is transatlantic recommendation of prostate gland evaluation, and the other one is BiFAB. BiFAB is an English single center technique. Target, a panel of 23 radiologists, urologists, pathologists connect together. They examine almost 73 studies, and then they come with the recommendation. And the whole scope of this therapy, of this lecture, is to give you an idea about these 2. So, can everybody hear me? So, Target is a 5-point scoring system. And the idea is, it was first introduced in 22, it was established in 23, and the idea is we are depending on diffusion, dynamic contrast enhanced imaging, diffusion weighted imaging, and T2 weighted imaging. We are including these 3, we are grading these 3 sequences together, and then we give every sequence a grade, and then we collect the grades. But among these 3 sequences, the most important sequence is dynamic contrast enhanced MRI. In PIRADS, the most important sequence is diffusion, okay? But not for focal therapy. So, T2 weighted imaging is important, diffusion weighted imaging is important, but the most important thing is dynamic contrast enhanced imaging. Because this only not only perfect that this lesion is active, it gives you an idea about the vascularity. It gives you an idea about the tissue characteristics. It's according to the dynamic contrast enhanced imaging that we're gonna grade the rest. This is the major sequence, but we're gonna use the 2. So Target using the 3 sequence together, grading all the 3 sequence together, focusing mainly on the dynamic contrast enhanced imaging. The thing about imaging the prostate, like imaging everything else, there are certain precautions. Okay, so the recommendation for this, the first thing, the MRI is after 12 months. So 9 months, okay. 6 months, I will not use it much. The idea is for the tissue to heal, it requires time. And before tissue healing, we are having problems with each and every single finding. So the recommendation in applying Target and also BiFAB is 12 months after focal therapy. We have to use all the 3 is mandatory. You don't have a dynamic contrast imaging, we're not using Target and BiFAB. There's not. The second thing, experience. If you're not reading 20 cases a month of prostate imaging, please don't put a report for the prostate, especially after focal therapy, okay? This needs experience. It's the learning curve, and it's hard. Now, negative MRI would normally say at 12 months, that means we might require a follow-up after a year, and duration depending upon what we found, and there are other recommendations, but again, 12 months and dynamic, diffusion, and T2. So we're grading everything into non-suspicious, suspicious, or equivocal, okay? We're giving each sequence, either it's non-suspicious, that means there's nothing that we're afraid of, or it's suspicious, or equivocal. And then we collect the scores. Here's the graph of how we use that. The major sequence is dynamic contrast enhanced. We grade it at 1 or 2 and 3, and then going to the next step, we're going into dividing the diffusion, either 1 or 2 or 3, and then the same for any, and overall score from 1 to 5. 1 and 2, we're good, okay? There's no evidence of recurrence. We're nothing to. 3 is equivocal. 4 and 5, you have to go into biopsy. Let's see the cases later on. The BiFAP, on the other hand, target, we are going to use the 3 imaging techniques. BiFAP, on the other hand, is a stepwise evaluation, meaning we first look at the dynamic contrast enhance. If it's enhancing, we go to the next step. If it's not, then the next step and the next step. But we know that it's all according to dynamic contrast enhancing. If it's not enhancing, this is not recurrence. If it's enhancing, then we go to the next step and then grade it and give it either 1, 2, or 3. So instead of the 5 grades in target, we're using only 3 grades. 3, go to the biopsy. 1, we're good, nothing suspicious. 2 is equivocal, we require follow-up and or biopsy. And again, target and BiFAP. BiFAP is a very recent recommendation. It was done by a single center in UK, and it's only in 24. So this is the BiFAP. First step, dynamic contrast, and according to this, we're given this. If it's negative, even if the diffusion is positive, we are not giving it either, it's only 1. Okay, but if it's positive, we are 100% going into mostly a very suspicious lesion. Now, till now, there's only 1 paper to compare in both grades, both grading systems, and that's only using just above 30 cases. This is a very new technique, and there is a great field for improvement. So if you really have cases, that's the time to submit the papers. Okay? So, quickly, BiFAP gives you a great sensitivity, but a very low specificity. Target, on the other hand, gives you a more specific results, but slightly less sensitive. That means if it's positive, that's 100% positive. Now, if it's negative, we might be missing a very small point. Okay? So that's the whole thing. Target is highly specific, BiFAP is highly sensitive. But this is only based on a 30 cases study. So we are still young. We still can do some work on it, and trust me, the whole states are working on that. Let's go immediately, just to cut off the time for the cases. This is case number 1, 78 male, BIRAS 4 lesion. We have a lesion here in the right peripheral zone, T2 hypo, positive on CT PET, PSMA of course, okay? That's the lesion. The patient underwent hypo. The scarring in the T2, no signal in the ADC, no signal in the diffusion and the dynamic, and no enhancement. This is definitely BiFAP 1, target 1. There is no evidence of recurrence. Second case, again, small lesion in the right BZ, underwent hypo. Hypo is the most commonly used technique. Myself, I'm working on something. Okay, it's a bit complicated, but it's also a very promising technique. Now, for this lesion here, there's an area of scarring. There's no much signal here in the ADC, but there is some enhancement in the dynamicals. According to this, this will go into BiFAP 2. That means it's equivocal. So, enhancement here, but no signal in the diffusion. Nothing. This is BiFAP 2. This is target 3. This is suspicious or benign. No, it's equivocal. This lesion requires follow-up. It's proved to be benign by pathology, but this is how BiFAP 2 works. Okay? I really buy BiFAP. I don't like big numbers, so 1, 2, 3 is easy. And again, we have enhancement. We have T2 changes of scarring, and we have some dark signal in EDC. This will target 5 by Fab3. Enhancement, dark signal in the ADC, some slightly hyper-intense indeed. Hello? So that definitely BiFab3, but it's target 3. Why is target 3? Because after we given a big number here for the dynamic, our signal in the diffusion is not much. But according to BiFab, this is definitely a recurrence, and it's proved recurrence. Again, scarring, signal, slight hypertension, slight enhancement here, nothing, slightly small signal here in the ADC. This is BiFab2. And unfortunately, it was proven by PSMA and proven by radical prostatectomy that is a recurrence. So as you see, there are a lot of missing out. They are not yet established. And if you're working with BiRads, you know it doesn't really work much in the transitional zone. So we are still exploring, and we still have things to add to this study. This is the classic case. This is T2 changes, ADC diffusion weighted imaging, very hyper intense, hypo, PSMA positive, and very enhancing. This is the classic BiFab3 target 3. So to sum up, we have target BiFab for imaging of post-focal therapy of the prostate. The major sequence is dynamic contrast enhanced. It's not contrast enhanced, it has to be dynamic contrast enhanced imaging. Okay, we're still using diffusion, we're still using the T2. Why I use this subject? Because it's still young, and we can add a lot and a lot and a lot. And if any one of you interested in doing that, I can join with you, and we have already our project going on. It's gonna be very interesting to add to this matter. Thank you.